It's late in the day. I'm glad somebody is in the audience to listen to me. And if you've got pressing engagements, I have two messages for you. One is don't miss the diagnosis, and the other is treat the patient. So you can go now. So premature ovarian insufficiency is defined as amenorrhea, sex hormone deficiency, and elevated gonadotropins in a woman who is more than 2 standard deviations below the mean age of the menopause in her population. In practical terms, it really means ovarian failure or premature ovarian insufficiency before the age of 40, and it can be primary or secondary. It's had a lot of different names, but in fact the term premature ovarian insufficiency is the first name this condition had, and it was coined by Fuller Albright in 1942. Primary idiopathic premature ovarian insufficiency affects 1% of women under the age of 40, so 1 in 100. 1 in 1,000 under the age of 30, and 1 in 10,000 under the age of 20. So it's uncommon, or so you might think, but there's quite a lot of evidence really to suggest that it is more common than at first we think. And this study here, a review of a 1958 birth cohort of British women, found that almost 8% of women in that birth cohort had either idiopathic or iatrogenic premature ovarian insufficiency. So almost 1 in 10. The incidence in this study was higher, 3 times higher, in the lower socioeconomic groups. And women who had premature ovarian insufficiency were twice as likely to report poor quality of life. And that, I think, is a theme that will come up again and again in this presentation. And even after 10 years from their diagnosis, those women remained disadvantaged in terms of quality of life and their physical and mental health. As I said, the etiology is predominantly idiopathic, although there are other factors. About 10 to 15% of women with POI will have a family member similarly affected. About 50% of those who present with primary amenorrhea will have a chromosomal abnormality. There is a huge list of chromosomal abnormalities, and I'm not going to go into those today, except to point out to you that the commonest ones are X-linked, and they are Turner syndrome, a triple X, various mosaicisms, and the FMR1 gene premutation, the so-called Fragile X syndrome, which affects 2% of all women with primary POI and 14% of women where there's a family history. There are other genetic links, autosomal translocations, including abnormalities of the FSH gene, G proteins, GALT genes, and other things, but I'm not going into those anymore today. There's a strong link with autoimmune disease, and about 25% of people who have POI will have thyroid disease as well. Importantly, about 3% will have Addison's disease, and if you miss that diagnosis, they will die. 2 to 3% will be diabetic, and a certain number will also experience the autoimmune polyglandular syndromes 1 and 2. There's a link with infection. Mumps oophorytis can cause premature ovarian insufficiency in about 2 to 8% of those who are affected by mumps. And then there is the small print at the bottom of the page. But today, the commonest cause for this condition is iatrogenic. It used to be ovarian surgery in days gone by when people were overly enthusiastic about operating on ovaries which had cysts, but today it's survivors of childhood and adolescent cancer. The 5-year survival from childhood and adolescent cancer is now excellent. It's somewhere between 70 and 90%, depending on the type of cancer involved. And in the West, about 25% of women who are diagnosed with breast cancer will be under the age of 50, and somewhere like 8 to 10% under the age of 40. There will be more than that number in Asia. So overall, about 8% of women will suffer from premature ovarian insufficiency of secondary causes. This is data from Nick Panay's group in London. And you can see here that in his study, about 42% of patients who presented to his clinic had idiopathic POI, about 43% were cancer survivors, and the rest benign conditions, with 2% being genetic. So, as I said at the outset, the most important thing is not to miss the diagnosis. And historically, it has been a diagnosis which has been missed over and over again. So be suspicious. Often the diagnosis is delayed. Often it takes years for young women with this problem to be correctly diagnosed. The signs are pretty simple. They are generally menstrual irregularities. They can be primary amenorrhea, as I've mentioned, or they could be secondary amenorrhea, but mostly it will be menstrual irregularities with or without vasomotor symptoms. As you can see, many of these women experience them, but not all. And it's all too easy for us to say to the young woman who presents with these symptoms that she's stressed, she's tired, she's exercising too much, it's the exams or whatever. It isn't. It can be something much more sinister. And so any young woman with over 3 months of irregular or absent menstrual cycles needs to be investigated. This is not rocket science. This is the stuff we teach our medical students. There are only about 4 things that crop up commonly, and they are hyperprolactinemia, hypothalamic amenorrhea, polycystic ovarian syndrome, and premature ovarian insufficiency. That's the big 4. And if you throw in pregnancy, maybe the big 5. So it's not a difficult diagnosis to make if you think about it. As with everything else we've talked about, a thorough history is critical, and particularly a family history in this case. Look for endocrine and autoimmune disease. Look for autoimmune polyglandular syndromes. Ask about surgery, about a past history of cancer, of any mental illness or disorders, and of course a family history of those things as well. And initial blood tests are simple: an FSH, an LH, a TSH, an estradiol, a prolactin, and if you're suspicious, a beta-HCG. If the FSH is raised, repeat the test a couple of weeks later, and then add other tests as you see fit. You should always screen for thyroid and adrenal antibodies. You should usually look for an AMH because that will give you some indication of ovarian reserve, and we've talked about that earlier today. Beta inhibin similarly, and then karyotype, looking for the FMR1 gene mutation, are all important tests, but pace these tests. Remember, this is a very sensitive diagnosis. The young woman who is involved in this is going to be completely confused and perplexed, and you need to treat this with sensitivity and pace the approach. Eventually, you need to do a pelvic ultrasound just to exclude multicystic ovaries, which can be seen with autoimmune oophorytis, and of course you need to assess their bone health and their cardiovascular health. The long-term consequences of premature ovarian insufficiency are just the same as they are for the menopause, and mostly they're not good. The only thing that is good about premature ovarian insufficiency is your risk of breast cancer is reduced. But all the other things, vasomotor symptoms, psychological symptoms, sexual dysfunction, fertility problems, early bone loss, and cardiovascular disease and related diseases are negatives. This is data from the collaborative reanalysis on hormonal factors in breast cancer, published long ago in The Lancet. And you can see that if your menopause occurs prematurely, then your risk of breast cancer will be reduced. There's quite compelling data from a number of observational studies that show that the risk of death from breast cancer is also reduced. So this is pooled data from the Nurses' Health Study, Parker, and Alison Mondal's data from cancer surveillance data in the United States. And you can see that if you're 40 to 44, your risk of death from breast cancer is significantly reduced compared to your peers who are still menstruating. That doesn't apply if your menopause occurs closer to the average age. There's also very good data from an old study by Dawn Willis, who looked at the relationship between menopausal hormone therapy and risk of death from breast cancer, in which she found that women who initiated hormone therapy before the age of 40 had a significant reduction in the risk of death from breast cancer. Obviously, you don't initiate hormone therapy before the age of 40 unless you're menopausal. Menopausal symptoms are sometimes, how can I say, considered irrelevant after what Dr. Sturdy's just said, but they sometimes are, and I just wanted to, in fact, say the opposite, that for this group of women, menopausal symptoms are very significant. They're more common, and they're often more severe than women who have a menopause around the age of 50. Certainly, if you have had a surgical menopause, then you have about a 90% chance of having significant menopausal symptoms. If you've had breast cancer and your breast cancer treatment causes you to become menopausal, then about 80% of you will experience quite significant vasomotor symptoms. Now, the etiology may not always be due to loss of estrogen. It may be due to chemotherapy, it may be due to adjuvant endocrine therapy, and it may be due to comorbidities as well. But the fact remains, this is an important problem for many women. 20% of women who are on adjuvant endocrine therapy to reduce their risk of recurrence from breast cancer will actually stop their treatment because their hot flushes are so severe. So we have to find a way to help them. And as has been said by others already today, vasomotor symptoms don't always go away in the first 6 months or 2 years. 30% of women will have persistent symptoms, and 15 to 20% of women, even in their 70s and 80s, will have hot flushes. The psychological impact of premature ovarian insufficiency is quite significant. There is an increase in anxiety, in depression, in loss of self-esteem, there's diminished well-being, and there's alteration to sexual function, always seen in these women. There are links, of course, to this. Quite often these things will be exacerbated by the delay in the diagnostic process, particularly if these young women are being told there's nothing wrong with them. Clearly, the underlying pathophysiology will have an impact on their psychological health, so it's more likely to be severe if they've had a surgical menopause or if their menopause has occurred because of a malignant disease. And there are also links to health status, psychological health status, and a woman's age, her relationship status, and whether or not she has children at the time of the diagnosis. So it's important for these women to be well supported at the time of their diagnosis, as I've already mentioned, and it's important for them to have an adequate support network as they go through the process of having all this sorted out. There's very good data to show an effect on cognitive function. I found it extremely interesting hearing Dr. Henderson's presentation, because I think we've all read his work before and realised that there is a tenuous link between the menopause at a normal age and the effect of estrogen on cognitive function. But a number of authors, including Dr. Napi in the front row, have found different findings for women who've had an early menopause. And the data I show you here is from the Olmsted County data, Lynn Schuster, who showed a relative risk of 1.46 for cognitive impairment or dementia for women who underwent a surgical premature menopause. She also showed that if you gave these women hormone replacement therapy, at least until the age of 45, that change in cognitive function was corrected. And I guess that's the first point that I want to make about treatment. These women require treatment. We are talking not about some trivial event or a physiological event such as a normal menopause. We're talking about pathophysiology here. Much could be said about the problems of fertility. Larry Nelson, who works for the NIH, described infertility as a socially constructed life crisis. And I think for these young women, it can be just that. Many of the women I see have been on the birth control pill, come off the birth control pill because their planning to start a family and find out that they actually may never have a child. It's been said that the risk of suicide is doubled in women who undergo premature ovarian insufficiency, and much of that is linked to their fertility problems. So counselling around this issue is critical. Idiopathic premature ovarian insufficiency arises either because you run out of primordial follicles, or you have follicles which don't function normally. And so when one does ultrasounds, you can see ovaries which have essentially no follicles, or still plenty of follicles that are apparently useless. But because of this difference in presentation, recovery of ovulation can occur in up to 50% of women. The trouble is, it's difficult for us to tell who they might be, or indeed for how long their menstrual cycles might return. And spontaneous pregnancy will occur in about 5 to 10% of women in whom idiopathic POI is diagnosed. Once again, that's difficult to tell, but it does mean that there are many spurious treatments being claimed out there in the literature which in fact have no beneficial effect, but which are being claimed to be effective because of this apparent spontaneous pregnancy rate. Spontaneous pregnancies have been reported in the literature amongst women who were on the birth control pill, probably because the birth control pill is inadequate to suppress the FSH levels that were elevated in the first place. So women can get pregnant if they don't want to, as well as not get pregnant if they want to, and the counselling of this is critical at the outset. Apart from spontaneous pregnancy, the only other options available include oocyte or embryo donation, pre-chemotherapy collection of oocytes or ovarian tissue, adoption, or what's described as child-free living. There's an effect of an early menopause on bone health, and as you would expect, it's greater than the effect of menopause at the age of 50 on bone health. Estrogen deficiency leads to bone loss. It's more rapid in the trabecular bone than the cortical bone, but it's manifest in both eventually. A surgical menopause appears to increase the rate of bone loss compared to a natural menopause. And if your menopause occurs before the age of 40, then compared to your colleague whose menopause occurred at the age of 50, your T-score by the time you're 65 will be 1 standard deviation worse. So there's a very significant effect on bone health. Menopausal age, in fact, correlates quite strongly inversely with increased fracture risk. And that's been demonstrated in a number of studies. This is data from the Study of Women Across the Nation, the US study, old now, 10 years old, but shows quite conclusively that if your menopause occurs early, your risk of fracture is 5 times higher than if it occurs at a normal age. Cardiovascular health is also implicated by an early menopause. We heard from Dr. Lobo this morning how important estrogen is in cardiovascular health for women going through menopause at a normal age. It's very important for young women as well. Cholesterol and LDL cholesterol rise quite quickly after the menopause, HDL not so much. Blood pressure and insulin resistance don't change initially, but do change eventually. And as we all saw this morning, the most likely explanation for increased cardiovascular risk is accelerated atherosclerosis. That risk increases with an early menopause, and it increases more with a surgical menopause. This is the Framingham data, which shows you that irrespective of whatever age your menopause is, your risk of heart disease is higher than your still menstruating peers. And this is data from ATSMA, who looked at a number of different studies looking at risk of early menopause on cardiovascular disease. You will see at the top here, the relative risk is 1.27 for a natural menopause, but if the menopause was surgical, the relative risk is 4.5 times higher. And this data from Rivera, again looking at American women, looked at the risk of cardiovascular mortality associated with a surgical menopause. So you can see the reference group on the left. The second group of women is a control group who were not menopausal compared to those women who underwent a bilateral oophorectomy and therefore a surgical menopause. And you can see that their risk of cardiovascular death was increased. The hazard ratio was 1.44. If that group here was divided into those who were and were not treated with hormones, the untreated group had a hazard ratio of 1.84, whereas the treated group had no increased risk. So evidence once again that it is critical that these women, particularly if they've had a surgical menopause, are treated appropriately. And again, similar data. This is from the Danish nurses study looking at the association between early menopause and risk of ischemic heart disease. And you can see here again, the effect is maximal with surgical menopause and not so great with spontaneous menopause for women under the age of 40. Much has been made of the risk of stroke, and there is data obviously that postmenopausal hormone therapy has a tiny, barely significant effect on stroke risk, but an early menopause is associated with an increased risk of stroke. This is Walter Rocker's data published just last year, and you can see there's a number of different studies, all of which show an increased risk of stroke if your menopause occurs early. So the obvious things associated with a normal menopause are more manifest with an early menopause. But as I said at the outset, the early menopause can be associated with other conditions as well. There's a link with thyroid disease, with Addison's disease, with diabetes, with polyglandular syndromes, with the dry eye syndrome, with lupus, with rheumatoid arthritis, and myasthenia gravis. And all of these things put together add further to the risk of early death associated with the diagnosis of early menopause. In this data from the United States, 68,000 women who experienced a natural menopause, who never smoked and never used HRT, were studied over a 20-year period. There were 23,000 deaths, and cancer and heart disease each accounted for about 23%. Cancer was the commonest cause of death in women under the age of 75, and heart disease in women over the age of 75. And women whose menopause occurred between the age of 40 and 44 had a 4% higher risk of all-cause mortality compared to women whose menopause occurred at the normal age. This is Dutch data, which shows much the same thing. If your menopause occurs before the age of 40, your relative risk of all-cause mortality was 1.45, significantly improved. And in this study, it was shown that for every year that the menopause was deferred, your risk of all-cause mortality death was reduced by 2% per annum. And this is, again, the Nurses' Health Study showing what you might expect. It's easy to say you're going to die from something, but what happens if the menopause occurs early, of course, is, as I said at the outset, breast cancer is reduced, total cancer is reduced, but of course coronary heart disease goes up. And about 40% of us will die of coronary heart disease and 3 to 4% of breast cancer. So there's a net harm in the whole equation. So premature ovarian insufficiency is an endocrine deficiency syndrome. It is not physiological. It leads to early loss of ovarian hormone production of both estrogen and progesterone, and of course of testosterone. It's associated with an increased risk of fracture, an increased risk of heart disease, of cognitive impairment, and of premature death. For most women, hormone replacement therapy will be the appropriate treatment. Obviously, they need to be encouraged to follow a healthy lifestyle, to exercise, to watch their weight, to have adequate calcium and vitamin D, and so on. But menopausal hormone therapy will be the cornerstone of treatment for the majority of these women. There is no comparative data to guide HRT use in younger women because all the major trials have been done in older women. And it's completely invalid to apply the results of WHI to young women with premature ovarian insufficiency. I must say the commonest question I get at the end of talks like this is, how long can I keep treating these women? Surely I can only treat for 5 years. because that's what WHI says. That is rubbish. These women should be treated until they reach the age of the normal menopause at least. And the main goal of our treatment is to mimic normal ovarian activity. And to do that, you will usually have to use higher levels of estrogen than are appropriate for women whose menopause occurs later. And in general, this will mean a dose of equivalent to about a 100 microgram estradiol patch. The combined oral contraceptive pill is an option. Many young women will prefer to take something like the pill because it's easier to explain to their friends than the pills that their mother takes. But there is some evidence to suggest that there is a lesser effect on bone health, and there is always the problem of 1 week out of 4 being sugar pills. Some women will require testosterone. The best evidence we have for need for testosterone is in women with premature ovarian insufficiency and surgical menopause. And as I said, treatment must be continued until the average age of the menopause at least. Now, this little drawing here is from a paper by Rafiq, Sterling and Nelson, published just last year, which is important for almost any medical condition, I would suggest to you, but it's absolutely critical for women who go through an early menopause. And what it explains is there are certain key factors that are important in improving the care of chronic illness, and they include easy access to expert care, the use of explicit plans and protocols, and it was fantastic to see the New Life Clinic project being launched here in India yesterday. Practice review and revision, always make sure you're doing the right thing and compare it with your peers and with the best standards in the literature. Patient education and behavioural change is critical, and supportive information systems. And there are not that many of those available for this group of young women. So we need to do better in that regard. So, my 3 chairs, ladies and gentlemen, in conclusion, I would just remind you, premature menopause is more common than you think. So be watchful and investigate thoroughly. Don't miss the diagnosis. Ideally, we should have a multidiscipline approach. HRT is the cornerstone of treatment, and it should be continued at least until the age of 50. The dose that you use and the type of therapy which you use may need to be modified over time. Remain watchful for signs of return of spontaneous ovulation and explain that that's a possibility to your patients. Otherwise, they'll think you're an idiot. And warn them about the possibility of unexpected pregnancy or the possibility of good news with the pregnancy. And last but not least, these women require regular monitoring of their general well-being, their psychological health, the possibility of autoimmune endocrinopathies, their cardiovascular health, and also their bone health. There are a few support networks available, and I've just listed them there. Thank you very much for your attention.